example. Idea is motor learning techniques. So these are the techniques which are important. The just opposite to the passive role of patient implied in neurophysiological technique, motor learning approaches stress active patient involvement. So it's just not the movement. Patient has to work on that. So if we start moving, then the recovery occurs. The patient collaboration is prerequisite and neuropsychological evaluation is required. Because those patients who are not motivated, are not interested, they do not improve better. As compared to those who are motivated, they do far better. Task specific is what we are talking about now. Just not the movement random, but task specific. So if I have to do the task, my action should be task specific. And context training are well accepted principle. So if someone is working in the office, we need to work out that and work in the office, how best he can use the computer. That's how to start working. So task specific training, context specific training are the principle in motor learning framework, which suggests that create the goal that are relevant for the need of the patient, not that you just want to do the random. So that has changed. Then there are various methods like Perfetti method and the Carr and Shepard method. These are some of the motor learning. Then you have actual pattern method. These are the various technology which are available in all over. No one technology to another. The person who knows the one technology best, if he adapts with that. So again, sensory integration or iris method is again popular, which is role of sensory stimulation. And you will hear a lot of sensory stimulation therapy being done nowadays. Music therapy is one of them along with that. So what are the merits and demerits of old and new technology? As I mentioned to you, there and how your patient accept that therapy so that you give the best result. It's like you are a good cook of a vegetarian food and your patient is a non-vegetarian. How best you may cook doesn't fit to him. Same way, other way around. So you need to understand that what you are good and what your patient accept, then the results are better. Therapies, there may be, these are the options you have available. You have to choose like how you select the dress for your wedding, depending on your own structure. That's how you have to choose the therapy. There are multimodal stimulation, which is another therapy where you can, these are more effective for learning. Like example, you use the mirror therapy and action observation. You use the motor imaging and mental training, or how you ask the patient to image that you is doing the movement, which we had heard a bit in the morning. It was not mentioned motor imaging, but that was a part of it. Virtual reality training with the help of the goggles, where you see the 3D and music related therapy. So you can combine this multimodal therapy. So these are mirror therapy. It's a very, very useful therapy. You put the mirror particularly into the hemineck line. And action observation or motor training in combination with concurrent physical training of observed action enhances the positive effect of task practice. So mirror therapy is creating an illusion and the patient looking at his normal leg start moving the leg which is hemineck leg. So that's very useful therapy. I think it is worth using this therapy in your department, doesn't cost much. And these are a comprehensive neuromechanism model for the mirror therapy, left brain versus right brain, how you deceive the person. And it's like, you are walking in a height. I just went for the sky walk. The floor was with the, transparent. How you feel illusion that you may fall. Similar kind of illusion you create and patient brain get confused and start working, that right hand is moving, start moving the left hand also. So that's the concept behind that. Then you have motor imagery and mental training. These are some of the, based on the conscious activation of brain region and network involving in the movement preparation and execution. And Because motor imagining is not dependent on actual ability to execute movement, mental training can be used early in rehabilitation process and even in severe paralytic patients. So I would say that if those patients who are severely paralyzed, if we start doing motor imagining and mental training, it would start working at some point in time. These are some of the focused motor imagining techniques. You can see them. They help in task learning, perspective approach, which are very, very useful and are based on the physical, emotional, timing, environment, and data. And if you see that comparison of embedded and added motor imagining technique, when you add the dynamic gait index, work balance scale, dynastic and visual imagining question score, they were higher than the pretest. So you clearly show that there is a great improvement. And you cannot just show the improvement on the video, it is not accepted. You have to show it on the evidence, on the scales, that this is the scale before the intervention and this is how much has improved after the intervention. That's how you have to do this. Then virtual reality training, we are trying to develop, India has been focusing now to develop the low cost virtual rehabilitation instrument. And you will find that many of them are available in near future, which again provide a multimodal, interactive, realistic, three-dimensional environment with a high level to suit each user's need. So you can put up the goggles and then start functioning with the hand. And Nintendo WI game technology represents a potential effective alternative to promote motor recovery. And we are also combining treadmill training or the robotic training with the virtual reality. So you'll find that you ask the patient to walk and you tell him to maintain into that area how to drive the car or how to catch the things. You know, these are the games which you play, the fish game and the car driving game, similar games being given to the patient and they are trying to walk or get through the hand. So these are the various other technology, virtual reality, which has been promising results. There is a three-step model of rehabilitation institutes, which has the dimension of the metabolism and plastic status of the brain, then enhancement of the plastic status of the brain and the spinal cord, and the selection and stabilization of newly formed optical structure. So that's the basis of the neuroplasticity or the recovery following the resettlement. And on that basis, the robotic devices has come. Now, what are the robotic devices? As you know that conventional gait training does not restore a normal gait pattern in majority of stroke patients. However, they talk with the MPC gait, they track their foot. But robotic devices are increasingly accepted among many researchers and clinicians and are being used in rehabilitation of the physical impairment, both for upper limb as well as for the lower limb. And the most common robotic devices for gait is task specific and they are repetitive movements. Specific repeated movement at a proper speed, and they have shown improvement in muscular strength, movement coordination, locomotor training in the neurological patient. This is the locomotor. Very expensive machine, cost 10 crore rupees. Again, we are trying to develop the low cost in India. If we can come out at some 50 lakhs in India, it will be useful. They are body supported. I just saw the body supported simple system at your acute stroke. So that's good. And as I mentioned to you guys that in 2004, I developed a local 25,000 rupees, gave my treadmill as a donation at Nair Hospital, develop a local 25,000 rupee support system through the help of putting a frame on the treadmill and developing through the lumbosacral as well as thoracic belt, putting them into the spring and attaching them into the frame. So that's how we have designed. And on that, you know, you have developed a gait trainer. These are some of the locomotives, what was expensive, the electromechanical or robotic system. Then you have FPS. This is another thing which has come. Functional electric stimulation. And it's a useful methodology for the rehabilitation after a stroke along as a part of the neurobiology. I tell you how it has been. It delivers electric current through the electrode to the muscle and its action potential in the peripheral nerve of the external branch and thus generate muscle contraction. Okay, it has been useful in rehabilitation of chronic anesthesia since very long period of time. So, if you have a patient with hand weakness and patient is not able to contract, if we use the APS in the forearm, they may be able to help the patient to grip the pen and write. Similarly, patient who have a dragging of the foot with the AFO, we put the APS on the arm and give an electrical stimulation which timed with the lifting of the foot. So during that time, because of this current, when he walked into that phase, the foot lifts automatically because of APS. And that's how you coordinate for a better smooth walk. So you can use it along with the AFO, or you can use it along with the support for the orthotic of the foot, or with the hand you can use it with a small spring and electric stimulation to use the hand function. So these are some of the new technology which you have to understand how to use them best. Then comes the brain-computer interface. This is something new which is going to come. Government of India is working hard to get the standardization of the BCI. I am one of the governing member on the BCI panel 7, which is dealing with the standardization of various brain-computer interface to be used in this country. So I know that how much research has been going on in this field, and this is going to change. You may not able to think how things are going to change. The hand function which is completely zero, or the vision which is not there, or the hearing which is completely impaired, how they are going to work out with the use of brain-computer interface in the near future. At the moment things are very, very expensive. How we are going to read through the electrode. So we have got 300 electrode EEG. Have you heard about 300 electrode EEG? So that's the machine which has just now been started at Trivandrum to do the study, to understand the brain functioning. So they are also trying to tag out on the dreams. So your dreams are also being made into, and how we are going to do it, all these data are going to come onto your mobile, and they are going to, through the various apps, they will consolidate into the program, that what program is required for you. So this is something which is very, very complicated, and it is going to be a future change of the game, which you will not be able, how you just see the TV and every program from all over the world is coming, people are showing. The same way the brain-computer interface is going to change the various functions in the future. These are some of the spectroscopy-based BCI. I don't want to get you too much confused, but there are definite new technologies which are coming, and I feel that neurologists need to take a big role into the neurorehabilitation for the reason that things like RTMS, BCI, and TCDS are something which is very, very important, and they have to lead for the treatment for the brain disability. So there are merits for the newer techniques. There are very demerits for the techniques. The demerits are few, but merits are many. You can see that challenges in, like VR used for the rehabilitation may be related to many. There are challenges pertaining to robotic use, but there are a lot of merits which are helpful, and we need to choose what technology we are going to use for our patient, which is economic as well as helpful. So I give you, this is what the treadmill which we made. So you can see that it is very primitive, but this is how what we have made. So this patient is cerebral ataxia, and it's the forward training. You can see that frame we made. You can see how we have supported his body, and these are the forward, this is the backward, and we also made a side walk. And you see the improvement in his gait. How you can see patient who was not able to walk independently, needed two people to support before we started the therapy. And now he walks independently. Not only he walks independently, he is off the treadmill in 6 months' time. And you see this gentleman got married, driving the tricycle, and working on computer. His life is completely changed. So that's how the training properly would work out. And not long, 6 months period. I also show you another case. There's a patient, I just wanted you to understand that how rehabilitation can change something which you think that nothing can be done. Go, now we are off. No. When the neurologist says nothing can be done, that's where the rehabilitation starts. That's how we start. So this is the patient. You can see that patient in coma. Venous sinus thrombosis came in coma on ventilator. Young patient. And look at the patient after therapy. How we started the therapy, the speech, swallowing, and it goes into the stages, one by one. And the swallowing comes. And the patient went home walking. So the rehabilitation is the only process which can change the complete concept of a patient from nowhere to the normal. I've only shown you 1 or 2 patients, but I've got hundreds of patients whom we have treated like this from coma to the normal. And I'm not going to do all of those cases, but please believe me when I'm saying that I've got many patients which has changed their life. So to summarize, the various rehabilitation approach has been developed and tested. A learning-based approach is advocated to facilitate the neural plastic changes and outcome of restoration. Given individual variability in recovery and the interaction between brain and network involved in the recovery, it is critical to identify not only the impact of the focal lesion but also viable brain network that may be accessed in this recovery process. So to conclude, neurorehabilitation as yet remained in the background of acute care, and still acute care is given more importance. Acute care physician cannot devote much time to the disabled patient outcome. I must thank Atulabh Vajpeyee, who is an acute care stroke specialist, has given so much interest in the rehabilitation also. That's very, very important. Everybody who is involved in acute care like him need to understand. And when I did a survey of the stroke people, how many of them has a stroke rehab unit? It's only 15% out of 200 strokes, which we want it to be 100%. A large number of neurological diseases lead to the severe lasting disability, and hence it is very, very important that specialized rehabilitation centers are developed and nurtured. And the scope of rehabilitation services has increased with therapies like botulinum toxin. I have not talked about it. I can show you innumerable cases which has improved after the botulinum toxin and has improved in the function, and will widen further with computer assisted and robotic devices. This was the first article I wrote sometime in 2016, which was published in ASNR, American Society of Neurorehab, about the neurorehabilitation. And from that, how I said that it is at an infancy. Today we have a chapter on the overview of neurorehabilitation in India and developing country in IAM textbook of neurology, which you can see is a great change where neurorehabilitation was not even looked upon, and today it is being part of the neurological textbook. Thank you very much for your attention.
Wonderful talk, sir. I mean, you have actually given a lot of insight, new things, and summed up the whole day's proceeding here. This is really fascinating. I mean, how, and as sir rightly pointed out, I mean, there is a future. There is a lot of future. I mean, all of acute care physicians should know about neuro rehab. So, lot of new things are happening. And those are real things, and in fact, some of them I did not know actually before listening to you, sir. So, like some of the things with your guidance, like robotic and those things, fortunately we have occupational therapists, so we are in 5% already, I presume. And we have a college for occupational therapy training. So, that's a blessing. Um, secondly, I mean, if there are any questions or comments, because sir, we would not spare you here. We would continue with you in because Adnan will be covering about Botox injection. That's a as this is a class, so there is no fixed schedule here. So 10 minutes he'll be talking about Botox, and sir would be just summarizing those Botox things, and followed by speech. Speech is another interesting subject. Couple of days before, I got a message on WhatsApp. There is a webinar, and I just logged in. Adnan, meanwhile, you can set up your computer. And sir, there was a talk about this MIT, melodic intonation therapy. You were telling this thing, global aphasia, Broca's aphasia. So which works in Broca's, not in global aphasia. That's an interesting, new thing. Very simple, cheap tool. And sir, as any of you who is interested in 2 days of music therapy in Mumbai, you are please most welcome. Be registered early. Sir, you have dates for that.
Yeah, so July 28 and 29, the Saturday and Sunday, we'll have 2 days program, which is with NMT Institute of Canada. It is a certified program along with IFNR. And Professor Michael Todd, the father of neuromusical therapy, would be in Mumbai for that 2 days program. So you are most welcome. I'll put it on the registration. We'll send you the brochure.
That's one thing one can make use of new things, like in addition to what sir was saying, music and yoga. That's also coming up as old thing, but labeled as newer tools if you use them judiciously. Meanwhile, Adnan, if you have set up, sir, any questions or comments, sir would continue be sitting here only. You can ask anything. Yush? Same thing, you saw that locomet. You have same. What difference?
Like after the locomet, we bought this one, robotic active gait therapy. The USP for this that it has inbuilt FES. Sir. The locomets don't have that. We have the inbuilt FES. So according to gait, what muscles are not activating, so we can activate that also. From last 2 years, we are working on the same, sir, and we have hand robotics. Get it. Right. But sir, one question we cannot answer the patient, that he is always asking ki how much time it will take, how much, and if the older patient who is 10 years old is, and how much?
I have a very simple answer. When somebody asks me how much time it will take, I tell them that, okay, you have to walk from here to Borivali. How much time it will take? It all depends on you, at what speed you walk, how much you don't stop in between. You walk 100 meters and sit down for 2 hours. What can we do? So you have to tell the patient everything entirely differ on you. How much you put effort, that will give the result. Therapies are just to assist.
Old case.
That will depend on how much reserve they have. So I give them another answer. How much reserve you have kept in your bank? How many FD you have? If you have FDs and you lost a lot of money, you can still recover. So it all depends how much unused brain you have, which can still connect your debts. Because if you are smoking 2 packs per day, drinking 2 packs every day, obese, diabetic, hypertension, you are left with no reserve. How it is going to recover? So you have to explain them in simple language, which they can understand easily.
Thank you.
You are done. Suraj, meanwhile, you get ready for next talk.
Very good afternoon, everyone. The difficult task is to keep all of you engaged post lunch because most of us get sleepy. But I'll summarize it in very short bullet points. And before that, I would like to thank Dr. Atulabh and all the dignitaries here, for getting such a good setup. It reminds me of my college days when we used to learn from our teachers, and now you have all the specialists flying over from everywhere to teach you. So this is a good opportunity for all of us to engage and learn, right? So I am going to talk about very specifically about a treatment modality called botulinum toxin, or in other words Botox, and it is always connected to history. So I'll just talk about the history of development of botulinum toxin. So it is the most lethal toxin available on the planet, and some of them before in the World War it was tried to be weaponized as well, and then fortunately it went into therapeutic use since a very long time, and it has been there for many decades, and whenever we pass year by year we learn something new about the novel toxin, and it is being used in many indications. So we'll just discuss a few indications where it is used, and especially related to today's talk, which is on spasticity as well as aches or migraine. So it was basically discovered in 1920, and followed by 1920 it was first isolated by Dr. Alan Scott in 1978. And the first approval was given in ophthalmology for strabismus and also for blepharospasms, and then it was given for hemifacial spasm. In 1991, it was renamed and rebranded from oculinum to botulinum toxin or Botox, as we say. And then we got an approval for cervical dystonia, which is a type of movement disorder, just like blepharospasm and hemifacial spasm in 2000. And then it was also approved in aesthetics in 2002, where now all the film stars, they use Botox for the hyperdynamic lines on the face. It was also approved in 2004 for hyperhidrosis, which is basically sweating of the palms and the axilla. And then in 2010 it was approved for migraine and spasticity. And it is now approved currently for both pediatric and adult spasticity. So this is a summary about the history of Botox and how it has now developed from the last 5 to 6 decades. If you talk about the structure of botulinum toxin, most of you must have heard about the bacteria called Clostridium tetanus, right? Which causes tetanus or Clostridium tetanus. From the same family we have Clostridium botulinum, which is another bacteria, and it secretes the toxin called botulinum toxin, and then it is then attenuated and used for commercially and in the therapeutic use. It's a very small molecule and it acts on the neuromuscular junction. Now this is the most important point, is that it inhibits the release of acetylcholine, which is a neurotransmitter which is required for the excitation of a muscle, right? And it inhibits the release of acetylcholine from the nerves, which causes relaxation of the muscles. So this is about the molecular size of the botulinum toxin, right? And then I'll just go for the mechanism which I've explained here. So you can see here, these are the vesicles which contain the acetylcholine, and normally what they do is they go into the skeletal muscle, they release the acetylcholine and you have a muscle contraction, and the muscle contraction is then blocked by this botulinum toxin. It's very specific to the nerve ending, which also makes it a little safer when you are using it on the muscles. So again, to describe it in deep, it actually cleaves the SNAP25, which is, if anybody wants to learn deeper about the pathophysiology, it cleaves the SNAP25 and then it inhibits the acetylcholine release. I'll just skip to that. Now, there are various companies which make a lot of botulinum toxin. So all the toxins are formulated differently. So they are not interchangeable. So when you use a toxin, you cannot mix two toxins and use them, because every toxin has a different strength. Now, one of the approved indications for use of botulinum toxin is cervical dystonia, where there is movement of the neck, abnormal movement of the neck, which is classified in movement disorders. And currently, for cervical dystonia, botulinum toxin is the drug of choice or the first line of treatment globally, right? So these are the types of cervical dystonia that you get. You get antrocholis, you get retrocholis, torticollis, and laterocholis. So there is bending of the neck, abnormal bending of the neck, which can be treated by this toxin. Then you have primary blepharospasm. So blepharospasm has a very old history. And earlier it was, whenever you saw a case of blepharospasm 200 years back, they would label that person as a crazy or insane person because of the blepharospasm. And they used to feel scared that there is some soul which has entered into the body, and but then it was treated first in 1870 by some other modalities, but then in 1970 by Dr. Alan Scott, it was treated with botulinum toxin, and there was 80 to 90% result. And since then, it has been a very good indication to treat with botulinum toxin. So usually it occurs in the later stages of life and not in younger ages. And there is a male to female ratio which is occurring more in women than in males. So there is frequent blinking and sometimes sustained contraction of the eyes, which leads to apraxia or functional blindness as well in blepharospasm in severe cases. Then you have hemifacial spasm, which is again a type of movement disorder where there is one side twitching of the face, which is also treated by botulinum toxin, and it also has very good results when you treat with botulinum toxin along with oral therapies. One more indication that you treat with botulinum toxin is juvenile cerebral palsy. So it is, I think there was a lot of discussion on spasticity and palsy as well since the morning, and this is a very good treatment modality to augment the treatment. It is not the treatment, but also it just helps to relax the muscles, and then primary goal is to rehabilitate the patient through other modalities as well as exercises. So the earlier you start in cerebral palsy, as in stroke also, early intervention is the need of the hour. Even in cerebral palsy, when you start off early with toxin therapy, it really helps to give a good course of treatment for the patient, and also enhances the longevity of the treatment that you are going to give along with this therapy. So this therapy cannot be individually used, but it is an adjunct therapy. So you have to always add 2 or 3 therapies with this, especially which involves physical exercise, as well as orthotics and other therapies. So this is a very brief about the kind of doses that we do. So this is the units for younger children, 2 years of age to 12 years of age. So for upper limbs and lower limbs, we decide the units based on some parameters like as the weight of the child, the muscle involved, and the type of muscle, and the level of spasticity. As Dr. Nirmal mentioned, you always grade it with a modified Ashworth scale. And once you have graded the patient, you can also choose or select the dose that you want to give. Then comes post-stroke spasticity. We've been discussing since morning a lot about spasticity. So again, you grade the patient based on the spasticity, level of spasticity, and then based on the grade of spasticity, you can choose and select the muscles that are involved. It might be a flexor type, it might be an extensor type. So whatever the type of spasticity is there, that can be treated with botulinum toxin. The muscles can be selected, injected, and then you can also add physical therapy and again get better results in spasticity. So if you see here for the summary, this is again spasticity. How does it occur? It occurs with the disuse atrophy of the muscle, which in turn leads to injury, and that injury further causes spasticity in the muscle, and it is a vicious circle. So you need to break that circle. You need to relax the muscles so that you can train the muscles for better strength and mobility as well. So if you do not do that, what happens is the tissue injury progresses and may lead to contractures with permanent deformities. So it also helps us to prolong the duration for exercises or rehabilitation and avoid complications like contractures and fibrosis. So this is the most common type of spasticity, which is called the flexor type. Upper limb is typically flexed, adducted, and pronation. The wrist is flexed and fingers are flexed. So this is 27 to 30% of the stroke patients come with this kind of deformity post-stroke. So this is the dosage chart for the adults. You can see that you have the upper limbs there, and this is how you select the approximate doses for each muscle in the upper limb. So these are the various common muscles which we inject. You can also inject other muscles as well, but these are the commonly injected muscles in the upper limb for spasticity. And also you can divide the doses based on the size of the muscle, and injection sites can be added. This is the chart for the lower limb. So the idea is to identify the muscles and also select the right dose. So right patient, right selection of doses, and then right output. So these are the things which lead to a good rehabilitation plan. So one of the most important indications today that we want to highlight is migraine, because the only drug approved apart from the other prophylactic therapies or modalities in the world right now is botulinum toxin for migraine, which has shown promising results, very good results for chronic migraine. But the key is to select the patient rightly under the criteria of International Classification of Headache Disorders. When you select and map the patient, even if it is a medication overuse migraine or a chronic migraine with more than 15 days of headache, these kind of patients get excellent results when you give botulinum toxin along with any other prophylactic therapy. So migraine is the seventh most debilitating disease in the world, and now it has also been labeled as one of the most expensive diseases, because it takes a lot of money to treat migraine, especially when you count the days off of the patient when they don't go for work. So those days, if you count together, it is one of the most expensive diseases, because it is a debilitation which cannot be seen but only felt. So mostly women are sufferers in migraine. So 80%, as again Dr. Surana said, that if you have a TCS, mainly it is males, but when you have migraines, mostly it is females. So the ratio is, again the opposite. So mainly women suffer from a lot of migraine. So this is the current protocol, which was the largest headache study globally. This is called the PREEMPT study, which was the largest open label study in the world, which was conducted for more than 20,000 patients, and 1,400 patients were selected for injections for 3 doses in a year. And this was a very promising study, based on which the FDA gave the approval for using botulinum toxin in migraine. So at the end of the third dose, nearly 75% of the patients have more than 50% response in migraine. So this is again the summary of the retention in the headache days. So I'll not go through this, we'll just move on to this. So these are the current indications that we use for botulinum toxin, which is adult spasticity, cerebral palsy, cervical dystonia, blepharospasms, hemifacial spasms, and migraine. So you can always treat your patients with a drug that is available for the last 6-7 decades, and it's really useful in our practice. Thank you so much.
Thank you, Adnan. Sir, I think couple of cases, Suraj, we show couple of cases, maybe for 2-3 minutes, and then we go to Suraj's talk, followed by, if we have a neurosurgeon colleague ready, we'll have a talk on neck pain and back pain, which is very common in clinical practice. I mean, all the physicians we encounter, apart from headache, neck pain and back pain. So medically, rehabilitation wise or surgically, how you manage them. So that is kind of so you are showing some box cases, sir?
Get the functional gain and then treat with the therapy to get the goal which I calculated.
Sometimes how do you decide, like, if some spasticity is there, if there is any fibrosis of muscle, whether Botox is going to work or not? So you do some EMG prior to that, or
No. So you come to know if a patient has for the lower limb we do the TADU. TADU tells you that whether patient has got complete tightness of the ligament or there is a muscle. But for the upper limb we come to know by the therapy. I just show you another case, 1 year. These are some of the landmark cases which shows that how botulinum toxin can help you in achieving something if you use the right kind of patient. Okay. So this is a 38-year-old man. He had a stroke at the age of 34 years due to the factor V Leiden mutation. And he received the treatment in his middle age. He had no other history or risk factor. He developed a sudden weakness of right arm, leg, and he was unable to speak at that time. And this was 2 hours ago while he was at work. His mental status, you can see, his speech when he came to us at Visakhya. His motor function MRC was 3 by 5. Sensory function he has decreased sensation to light, touch and tingling. His reflexes were 3 plus. He has an intact coordination of left upper and lower lip, mild dysarthria. All other cases are normal. The rest of the features are normal. So MRS 3. Self-care was 22 by 28, sphincter control 4 by 7, and mobility 12 by 6. And we checked for the action research arm test, which is for the hand, which was 18 by 57. So there is a limited ability to perform upper task. The functional reach test was 10 centimeter, limited reach on the affected side. And 9-hole pack test is 45 seconds, which is a prolonged time compared to the fine motor task. Why I want to show you this is that any patient you have to establish the exact scales which gives you what is the dimension of his disability. Just video showing that this is not doing, this is done, is not good enough today. Evidence has to be a proper scientific base. Mass was 1 plus in the right upper limb. We gave bottom toxin in the flexor of the elbow, wrist and finger. And he has a reduced hand swinging. And this was the first dose. And this was done as he was not able to afford. This was done during the IFNR Con 23 in Mumbai as in the part of the workshop. So we gave the injection there free of cost. This is the patient. Video is not working here. Yeah. So as the patient, and you could see that he's got an ability gate. His hand, you can see that. Post 1 year. This is 1 month ago. And he got a job in the police now. He has been selected, he has been fitness. He wanted to get a job. His hand was weak, he was not able to use. He is able to do all the tests so that he can get a job in the fitness. Very thankful to us. So, using the right doses for the right patient, the right muscle is the key with the goal. To do that, that comes by experience. It's not over a period of time. I started using botulinum toxin from 1992. So the first to start in this country. And it has taken years for me to understand about the doses, where to give. But the therapist helps you because they give you the assessment that these are the muscles which are bothering us, and you target them. Thank you.
Thank you, sir. Suraj, you are ready? So he's Dr. Suraj. He's qualified speech and language pathologist. So basically, speech is also part of cognition, language, speech. So meanwhile, Suraj set up his laptop. So basically, speech, we have post-stroke speech impairment also, aphasia, dysarthria. So these are a part of all cognitive functions, but you need really amount of training for becoming a speech therapist for these post-stroke impairments. Arun, you are ready with your presentation? Meanwhile, if you can bring yours, then we fix this. After this, we will have one presentation. If you are not tired, then one more. Last would be mine. If you are not tired, I'll do it. Otherwise, maybe we can do it in the dinner session. So that I'll skip. We'll do a democratic process. We'll do voting for that. If you want mine, I'll do it. Otherwise, I will not. So we'll be secret ballot. Okay. So that there is no force that you can listen to me. So we will stick to our time. In any way, those. Dr. Praveen, any experience of Botox in migraine? Have you used Botox in migraine?
Useful in chronic migraine, which is defined as more than 15 days of headache in a month. So headache should not be more than 15 days. So best useful in patients of chronic migraine. It can be used in other patients of severe migraine, and in fact they will respond. But you are sure that you are injecting the chronic migraine that they will respond.
So meanwhile, this speech will take maybe in the end. So before that, I think because both neurosurgeons are here, so Amit Endu has also come here and Ajit is also here. So I think we'll take this very common, very important topic of neck and back pain. So we will have, I think if both of you can please come up, Dr. Ajit, Dr. Amit Endu, please come here on the dais. We'll have this panel discussion on neck pain and back pain. Mostly because neurosurgeon deals with this problem more often. Obviously, neurologists and physicians, they also face this problem in their OPD. So basically, how long, what are the indication for surgery, how long you need to treat them, what are the medical treatment. So this is primarily a problem faced by neurosurgeon. So we have Dr. Ajit, who is, everybody needs no introduction. He's a famous spine surgeon and neurosurgeon as well. A big round of applause for Dr. Ajit. And joining him is Dr. Amit Endu. Again, a fantastic neurosurgeon. We all know about him. So they are senior consultant neurosurgeon at present in Paras in Udaipur. And I think Pacific neurosurgeon is still busy in case maybe he will walk down anytime, so if he is free. So Dr. Arun is again neurosurgeon. He has done his neurosurgery from All India Institute of Medical Sciences. At present he is working here with us, and he'll be talking about this. Please, you have a seat. Please sit down. And from rehabilitation side, I think what you do, Dr. Piyush, we will be asking you about rehab aspect. So you come over, and Dr. Sonam, both of you please come over here on the chairs. And Zafar is missing. Okay, no problem. So medical aspect, you can ask me. We have neurosurgeon, neurologist, and you also have interest in backache, right? And you have backache also. No. Okay. So I think you will join us. Please come here, sir. Because this is going to be, because this is an area, gray area, neck pain, back pain, what to do, how to do. People just linger on with this for years altogether. So there are no, I believe that there is no consensus or guidelines. Physiotherapy therapists will keep on doing physiotherapy. Neurologists will keep on prescribing medicines. So yes, over to your own.
Good afternoon, everyone. So I'll be talking about the degenerative spine disease. I would be talking about craniovertebral junction anomalies, which is another proper cause of neck pain. So coming to the anatomy. So for the UG students here, so we have the disc, which has two components mainly: the annulus fibrosis, which is a thick fibrous radial tire, and inside which is there is a soft jelly, the nucleus pulposus, which is the embryological remnant of the notochord. So this is not exposed to the humoral immune system during development, so which has functional implications later. So the pathological changes as age increases, the water and proteoglycan content decreases. The arrangement of the collagen fibers also gets distorted, and the tears in the lamella. This results in decreased height and volume, and also decreased resistance to axial loading. So the major pathologies are the compression, myelopathy, and the reticulopathy. So there is a compression to the nerve roots or the spinal cords, which may be caused by the bony spurs, thickened ligamentum flava mainly, and the herniated disc. And what we call myelopathy, which is a reduction of the spinal cord's ability to send signals to the brain and body. So this is found out in the examination by presence of increased reflexes, and the compression of cord causes weakness, numbness, and other deficits. So the radiculopathy is specifically related to the nerve roots. So there is reduction in the nerve roots ability to send signals, which is associated with numbness in the area of the nerve, and it is not limited to a particular dermatome asset. And there is a sharp shooting pain which will worsen with certain movements, and there is numbness, weakness, and tingling. And most common radicular pain is seen in sciatic region and followed by brachial. And there is a lumbar canal stenosis. So the major mechanism is mainly maybe disc or thickened ligamentum flava, and also in there will be myelopathy or neurogenic claudication. So in neurogenic claudication, what happens is as the patient walks, there is congestion of the epidural veins, and there is added compression which causes the claudication, and there may be arthritis and bony spurs. So the symptoms, it may be asymptomatic or symptomatic. The red flag signs to look for in such case is the presence of cardiac venous syndrome, which is characterized by back pain, bowel and bladder incontinence, saddle anesthesia. So this becomes an acute emergency, and it should be operated as soon as possible. And myelopathy is characterized by pain with exaggerated reflexes, and radiculopathy is radiating pain towards a specific dermatome. So, and when there is a fever, when the pain gets worse at night, and there is unexplained weight loss, and when it continues for more than several weeks or months, we should consider other causes like a malignancy. And neck pain with difficulty in breathing or swallowing is in cases of high cervical lesions. So these patients should be shifted to ICU, and they may need intubation. And the risk factors for degenerative spinal disease, mainly genetic predispositions, smoking, poor diet, not managing adequate weight, occupational risk associated with heavy weightlifting, and a sedentary lifestyle. So the major mechanisms of intervertebral disc degeneration are the disc bulge, the annular tear, and the herniation. So coming to the imaging is not the be all and all of all things. It should be correlated with the clinical examination, and the patient may it may show a positive imaging in around 30% of the patients, but it may not the deficit may not be related to the imaging findings. Could be even be an MNT. So there are several cases in which these cases have been operated and the patient has succumbed to other causes. So Coming to X-ray, this is the most basic one, which shows spinal degenerative changes, but not herniated disc, and it rules out major underlying obvious underlying problems. CT is relatively less used. MRI is the best imaging modality. So the disc bulges classified based on the type to symmetrical and asymmetrical. And asymmetrical is seen when the displacement of the disc material is equal in all direction, and asymmetrical is when is usually seen in scoliosis patient. And the distribution, it may be generalized or circumferential. So you can see there's a normal disc and the symmetrical bulge. So there's a concentric extension of the disc, and there's a asymmetrical bulge. The annular tear also has been classified into three: the concentric tears, the radial tears which extends outwards, or the transverse tears in the peripheral or rim. So the imaging findings in case of this annular rupture, what we can see is this is the T2 weighted imaging. So it is hyper on T2, and this is the T1 weighted MRI. So it is not usually seen in that, but when we apply contrast in the T1 weighted imaging, we can see that there is a enhancement of the involved part of the disc. So disc herniation, is the localized displacement of the disc material, the nucleus, cartilage, and the fragmented apophyseal bone and the fragmented annular tissue beyond the limits of the intervertebral disc space. So it causes compression of the nerve roots and causes the symptoms. So it is most commonly seen in the lumbar region, and second most common site is in the cervical region, in the C5-6 and the C6-7 disc space. And thoracic, it's very uncommon because there is good muscular support from the thoracic rib cage. So it is not subject to the loads which is seen in the lumbar and cervical region. And the herniations usually occur in the posterolateral region most commonly. And what happens is in this region there is no support by the posterior longitudinal ligament. So herniation is seen in this region. It's a normal disc bulge, and this is the annular tear. You can see the defect in the annulus and the disc protrusion, and the in the subligamentous disc protrusion, it stays behind the posterior longitudinal ligament, and transligamentous there is breach of the PLL, and it is sequestrated disc fragment. It gets completely separated from the disc. So as you can see, this is a disc bulge, and there's another anomaly. You can see this is a small nodule you can see here, and the type of disc herniation we can classify into broad-based and focal. So this is a broad-based disc herniation, and this is extruded disc, which is defined as the herniation which the base is narrower than the apex. So as you can see in this, and so I'll skip the imaging part because most of the audiences are students. So coming to lumbar disc herniation, I will talk about the basic etiology, pathanatomy, prognosis, and location, and also the epidemiology. 95% is seen in the L4-5 and L5-1 levels. Most common is in the L5-1. It's more commonly seen in the 4th or 5th decade, and only 5% become symptomatic. So even if there is some finding in the imaging, you should not try to rush and treat it. The male to female ratio is 3:1. So the pathanatomy is the recurrent torsional strain leads to tears in the outer annulus, which leads to herniation of the nucleus pulposus. And the prognosis, so in most of the patients, so as I told from the very beginning, the disc is embryologically originates from the nucleus pulposus, which is the embryological remnant of notochord. So it is not exposed to the humoral immune system. So majority of the cases over time this gets reabsorbed by the immune system. So So 90% of the patients will improve even without any surgery. And the macrophagocytosis is the mechanism of the resorption in these cases. So classification, central prolapse is much less common. Posterolateral is the most common because there is no support by the PLL. The foraminal or the far lateral, in which the herniation occurs outside the spinal canal and compresses only a particular nerve root. So it's the least common actually. The axillary, it affects the axilla of the nerve root. So coming to the pathological classification, as I already told, inclusion. So axis restriction. So this is a far lateral herniation. So this is a spinal canal and the spinal cord inside this occurs outside the spinal canal. So cardiac canal, this is a serious neurological condition, and this is an acute surgical emergency and should be operated as soon as possible. So it is characterized by 11 findings mainly, such as sensory loss in the saddle region, bowel and bladder. So will be an element bladder, anal and lower knee jerk, ankle jerk will be absent, and there will be severe bilateral leg pain and lower extremity weakness. So diagnosis mainly already told, neurological examination is the most important thing. Imaging is only secondary actually. So we have to look for both element and human findings. If there is any if there is a mix of both, we should try to rule out other pathologies like a motor neuron disease, etc. And so MRF provides the most accurate assessment. Other modalities like EMG may be used to aid the diagnosis. So symptoms, we have to assess the specific dermatomes and myotomes while assessment. So this is a case of left-sided lower lumbar disc herniation. So the patient is unable to exert pressure on that region. So we have to so in the specific the L45 disc herniation, the mostly the traversing nerve root that gets involved is the L5 nerve root, so which is characterized by pain and numbness in the lateral leg and the first three toes. The dorsiflexion of the great toe is impaired and there is difficulty in walking on heels. Whereas when the S1 disc is involved in the level of L5 S1 disc space, so we have involvement of the back of calf, lateral heel and from foot to toe. So in this, the plantar flexion is impaired and patient will find it difficult to walk on toes. So in how to assess a different nerve root. So first the L4 one, we have to look for ankle dorsiflexion. L5 by looking at the great toe dorsiflexion, and the S1 level by plantar flexion. The provocative test used to find whether there is any compression in the foramen or the lumbar, spinal canal. So the major ones are straight leg test. So this is the patient is laid in supine position and is asked to keep the knee straight and asked to flex at the hip. So tension. This is a tension sign for L5 S1 nerve root, and contralateral straight leg raising test. So it is much less sensitive but more specific. Lassac sign is in which the SLR is aggravated by forced ankle dorsiflexion, and there are several other named tests. So this is a straight leg raise test. So it produces pain and paresthesia in the leg at 30 to 70 degrees of flexion. So this is the most important and predictive physical finding for identifying who is a good candidate for surgery. So coming to X-ray, so we have to look for bony swelling. This spindle is not usually visualized in this in the X-rays. So and CT scan, we have to look for any bony pathologies, fractures. We have to look at the facet joint. And MRI is the most commonly done investigation in these patients and investigation of choice. So as I suggested before. So it is around 30% of the population has this in their MRS, and it may be a normal finding. We have to always correlate clinically before taking up the patient for surgery. So the several differential diagnoses. So it may the we have to rule out secondary tumors, multiple myeloma of the spine, which can cause vertebral dissection and the sparing of discs. There may be fractures, infection, tubercular mainly, and sacroiliac joint dysfunction. So natural history I've already told. So 90% improve without any treatment, and in the 10% who doesn't improve with conservative treatment, selective nerve root corticosteroid injection may be tried, and in them 50% improve with this steroid injection, and of them only 5% of the total may be like candidate that really required surgery in this pathology. So other treatment modalities are NSAIDs, muscle relaxant have some effect. Steroids are not usually suggested in this pathology, and physical therapy is very important in this patient to increase the strength of the back muscles and also increase the bone density. So coming to selective nerve root corticosteroid injection, it may be epidural or selective nerve block. So it leads to long-standing improvement in around 50% of growth. So, and coming to surgery, so finally, so this is indicated when there is persistent disabling pain lasting for more than 6 weeks that have failed non-operative options, and if it is being done at use under epidural injections also, and when there is progressive significant weakness on examination, and when there is cardiac arrest syndrome, we cannot wait. We have to take the patient as soon as possible. So the standard surgery, the gold standard is the laminotomy and discectomy, the microdiscectomy procedure, the open one. So in this, what we do is we make space in the vertebral lamina. We try to assess the neural foramina and visualize the prolapsed disc, and we use special devices like nerve hooks to complete the dissection, and also the special curettes to complete the dissection and make the axil of the nerve root free, and we have to check all around the nerve root 360 degree whether there is any residual compression, and then finally close up the patient. So usually we don't do any fixation for this patient. For these patients, the complications are the dural tears, the recurrent pain, and the vascular catastrophe caused by breaking into the anterior annulus if you are doing an overzealous discectomy and injuring the vessels which lie anteriorly. There may be some instability if you are doing discectomy more than around 2/3 of the disc, intervertebral disc. And discitis is a dreaded complication in which there is infection of the post-operative infection of the disc, so which causes severe pain to the patient. And coming to cervical disc herniation, this is most commonly seen in the level C5-6 and C6-7 intervertebral disc space. So it can affect the back of skull, neck, shoulder girdle, scapula, arm and hand, and nerves of cervical plexus and the brachial plexus can be affected. So all the symptoms of radiculopathy, myelopathy will be seen. So coming to localization, we have to look for individual dermatomes and myotomes and localize the lesion before taking up the patient for surgery, and have to correlate whether have to confirm that this correlates with the imaging findings before taking up the patient for surgery. So the different tests is a Sperling test in which we flex the neck towards the side where the patient has pain and puts pressures over the head, and when there is increased pain, we consider it as a positive test. And Levin sign is more commonly seen in the central herniation, so it's caused by increased tension of increased tension on the cord caused by the disc on flexing the neck. So other test is a Hoffman sign, which is a UMN sign. So this is done by tapping the tapping or flicking the nail of the middle or ring finger to produce a flexion of the index finger. The Lermite sign, as I've told before, the Sperling sign also I've described before. So MRI, as you can see, other causes should also be considered. So this uh, and it should correlate with the examination. Treatment mainly same. Mainly we have conservative treatment is same as that of the lumbar one. So medications, physical therapy, and also steroid injection. The surgical options available are mainly ACDF, which is the anterior cervical discectomy, in which we remove the intervertebral disc, and usually the cervical spine is mobile segment, so the level of instability is much more compared to the lumbar one, and we cannot get away with the simple discectomy in a cervical one. So fusion is usually warranted, and there's also posterior cervical discectomy, which is rarely done nowadays, and in most of the cases nowadays artificial disc is placed, usually made from a PMMA artificial material, or if that is not available, iliac crest graft, autograft may be used. So this is a basic description of the ACDF, anterior cervical discectomy and fusion procedure. So incision is marked, the level is identified using a CR. He remove the disc, and after that we can place a graft between in the disc space, and then we fuse the vertebra using titanium plates and screws. So coming to the another pathology, which is a spinal canal stenosis. So this is the abnormal narrowing of stenosis of the spinal canal that may occur in any region of spine, and this causes restriction of the spinal canal, and it causes neurological deficit, and this is also the most common cause of neurogenic claudication. So as a patient walks, already there is a tight space, and along with that, when there is increased blood flow during walking, and there is a epidural venous congestion which causes neurogenic claudication. So the symptoms are pain, numbness, paresthesia, loss of motor control. So the incidence is around 20 to 25% in patients more than 65 years. So it's slightly more common in males. So location is most commonly in L4-5 level. So it can also be classified into central canal stenosis. So this is the central canal stenosis, and the lateral is stenosis, and also the foraminal stenosis. Symptoms are usually same as that of lumbar disc pathology. There may be bowel bladder disturbances, but compared to the disc pathology, Kodak-Kone syndromes are much rarer. And this is more of a chronic pathology rather than acute emergency. So the examination findings, you can see this KEM sign, the SLR sign, and also in the Valsalva test, what happens is the epidural venous tension occurs, so the radicular pain gets worsened during this in the lumbar canal stenosis. And many people may not have any deficit also. So in the posteriorly, you can see the black and thickened ligament of flavum. Here also you can see. And so in the major treatment modality, coming to the non-operative one, as I discussed before, same as that of the disc pathology, NSAID steroidal injection, and the surgical treatment is the wide pedicle to pedicle decompression. So it is indicated when there is persistent pain for more than 6 months that has failed to improve with non-operative management, and when there is progressive deficit. So, and in this case, fusion may be warranted when there is segmental instability, such as anterior slippage of the vertebral body, which is known as a listhesis, which may be a degenerative spondylolisthesis or ischemic spondylolisthesis, and there is surgical instability created by a complete laminectomy or removal of more than 50% of the faces. So, coming to spondylosis, well, it's a broad term actually, not specific. It means that there is a degeneration of the spinal column from any cause. So maybe due to osteoarthritis, age-related wear and tear of the spine column. So, coming to spondylolisthesis, in this there is a slippage of the vertebral body, one over the other. It may be anterior or post. Most commonly it's the anteriorly, maybe posterior also. So as you can see, and it's graded into 4 based on the percentage. 0 to 25 is grade 1, 25 to 50 is grade 2, etc. So, and it also is classified based on the etiology into dysplastic, ischemic, degenerative, and traumatic, pathological, and iatrogenic. So imaging findings, X-ray is most important in investigation to rule out allostasis. So, and it should be done in positions of active flexion, extension, and neutral. So this is a dynamic thing that this is finding. And clinically, the patient may have axial pain, leg pain, usually in the L5 region. There may be neurogenic claudication caused by the spinal stenosis, characterized by buttock and leg pain that gets worsened with walking. And the Kodak syndrome is rare. And the treatment in this conservative treatment is the same as before. And the operative one in this fusion is usually warranted if the grade of lysis is much higher. And when there is progressive neurological deficit, sleep progression, and Kodak syndrome. So, the operative options, main one is the posterior approach actually, the L4S1 decompression with pedicle screw rod fixation, and it's indicated in high-grade lysis. The anterior surgery is anterior lumbar interbody fusion, which is not commonly done nowadays. So it has a good outcome of around 87 to 90% at 2 years. So this is a case of lumbar fusion at this L4 vertebral body, L5 vertebral body with cage in between. So, and there are this field is evolving rapidly, and nowadays there are several other minimally invasive options available. Even though the literature is not, it's literature is still evolving in this minimally invasive, on this minimally invasive approaches. The various options available are the unilateral biportal endoscopic spine surgery, the Gore system of spine surgery developed by the orthopedician Dr. Gore at Pune, the MIS spine systems provided by the Medtronic and Jesco companies. And nowadays, instead of taking multiple shoots during surgery, using the CM, the option of OARM, and using image guidance to avoid radiation exposure to both the surgeon and the patient is also available. And the MACERX is another modality in which the robotic arm helps to guide the placement of screws. So that will be all. Thank you. Any questions?
Thank you very much. So, I mean, very extensive coverage of two things together. So I think let's make it like this. Dr. Ajit, what is your, from clinical standpoint point of view, what is your approach, let's say, for a patient with lumbar pain? How would you deal that?
Very nice presentation and coverage of the topic. Mostly, as clinicians, we are restricted to the lumbar disc or cervical disc. Mostly in MRIs, we are looking for the disc herniation. That's why sometimes we are missing the major things which are also there when there is no disc herniation. So whenever we are approaching a patient after clinical examinations and looking for all the red flags and signs of myelopathy, radiculopathy, cauda equina, then infections. So everything we try to first formulate in our mind what it can be. But we are seeing 90% most of the patients are not showing anything in the MRI. Still, they are having some kind of pain. And they are going from one clinician to another, neck pain, back pain. And what I feel, the spine is very complex and is divided between neurosurgeons, spine surgeons, orthopedic spine surgeons, neurologists, and everybody has a specific view of looking at the spine. Suppose an orthopedician will try to look for the bony problems. We will see the spine as a bone. As a neurosurgeons, we see spine as nerves. And combination of all. If you want to be, perfecting in the spine, then you should have done work with the orthopedician also, and along with the neurosurgeon. So to be a complete spine specialist, you should have exposure to both the specialties. And regarding one more thing which I want to emphasize is the X-rays. Usually we think that X-rays are now obsolete and doesn't give much information. But in many cases, you see that a patient coming with almost normal kind of MRI. But when you get an flexion extension X-ray, you will find some subtle listhesis occurring at that point, and you may be able to diagnose a disease which was actually looking normal to the many clinicians. So then another problem is with the facets, like joints. The spine has joints. So we have to focus on the joints also along with the disc. This is the most common thing which we are focusing on. The other is the disc looks normal, other things look normal, but you see some fluid in the joints. So you have to find out what all you can offer to such patients which have a facetal arthropathy. Then spine has got muscles. So there are patients who have got muscle weaknesses, like in polio or any other, muscular problems. So they will slowly develop the back pain or neck pain because of the imbalance in the muscles, weak muscles and the strong muscles. And the curvature of the spine is also very important. Sometimes everything looks normal, but you will find there is only some kyphosis, scoliosis, or you find there is spasm. So what can be the cause of the spasm? So all things we have to look by our experience and by our way of we have to choose the modalities. There are so many modalities listed today. So we have to choose which is the best modality for the patient. Suppose sometimes we are confused whether we have to go for a fusion, means fixation, or we have to go simply with the discectomy. So it depends on the occupation and lot of other things also. What are the expectations, what the patient wants to do after getting the surgery done. So as a neurospine surgeon, this is some of the points I wanted to emphasize. Let the others also.
Do you have any predilection for any form of medical treatment or rehab treatment? Any preferential treatment for your patients? Let's say before going to surgery, do you
Yes,
have
yes.
any kind of specific preferential?
Medical trial. So we should have a good conservative trial before embarking on the surgery, except in few cases of the red flags, like cauda equina, which is you have to be very, 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 you have to do in emergency. Weakness of the foot drops and all, weakness of the muscles, then you have to go for the surgery as early as possible. Myelopathy and all. But for the patients only coming with the pain, then we should have a good conservative trial, maybe for 3 months. I am giving.
That's what
Along with that, we can add the adjunct treatments like epidural steroid injections also can be tried with the patients, which can be done under CM or CT scan, whatever modality you are doing. Then suppose the role of physiotherapy, as I have mentioned that weak muscles. Sometimes the patient is having pain just because of the weak muscles. So if you can do the strengthening by physiotherapy, then definitely he will have improvement with the conservative management. So it is a multimodal approach where there is a clinician, there is a physiotherapist, there is a pain specialist, all have to work in unison. And in case after surgery or with weak muscles or any other deficits, rehabilitation is very important, as that will lead to strengthening of the muscles and other way of what ergonomics, what we say, how to use your body properly so that it doesn't come back.
Thank you. I think that's. But, I wanted to ask basically any specific choice. Do you use steroid in your armamentarium in conservative treatment? Do you give preference to NSAIDs or to some centrally acting muscle relaxant or to some peripheral acting muscle relaxant? Any kind of preferential medical management you give to your patient? I mean, or there is no particular choice.
Yes, actually we are using combination of all these. We are using the this pregabalin and gabapentin also. We are using the muscle relaxants. We will try to use non-sedating, which is having less effect on the daily activities of life, because you are adding the gabapentin, then you are adding some sedating muscle relaxant. Patient will come with that I am sleeping all day. So you have to means you have to what make a fix whatever your schedule you want to be. There is no actual preference. It depends on the patient to patient.
That makes sense. Completely agreeing. For cervical, for neck pain, Dr. Amitendu, again, I would say as a neurosurgeon, when are you, tired of, getting patient treated by neurologist or physiotherapist? I mean, when would you think that, this is enough? You have overdone your conservative management. What is that endpoint for you?
Yeah, the end point, I would rather pick up from the natural history of the problem. Like if somebody has a neck case, I don't think the time is still there. I have collection of few cases with an operative video. In few of the circumstances, if the neck pain is not getting settled with the physiotherapy, with the anesthesiologist, with a good looking MRI, where you just see a annular spot, which is just protruding or just touching the nerve root. Sometimes I feel it is better to get a EMG and see done. That will give the idea whether the muscles are getting atrophied or the nerve conduction is getting abnormal. And for me, that is the end point to pick up operative decisions. Now, coming to the operative decisions, before we do it, my checklists are number one, whether it is conforming to the radicular segment involved, and then the duration of the pain, then the overall global status of the patient, whether it's a young patient, whether it's an old patient, whether any pre-morbid or comorbid factors. Like one of my cases where the patient was having this pain, and then suddenly she developed weakness of the hand, and MRI was normal. And then subsequently on a CT scan, it shows there's a problems in the bone. And then MRI will contrast reveal that there is a abscess kind of thing which is forming on the anterior prevertebral space, and which ultimately came out to be a tuberculosis of spine. In second
So
thing,
you do MRI, contrast MRI in all the cases?
No. If you don't find anything on abnormal and MRI, would you go for contrast MRI?
yeah, few cases of my learning where both lumbar spine as well as the cervical spine, where the MRI picked up some intramedullary lesions with a contrast, where the disc is absolutely normal. So I think it should be considered if the pain is for a very long time, if the pain is of a radiating type, if the pain is in the night-time pain, and when we are clueless what is happening in the patient. So these are the few very selected circumstances where we push a contrast. And if there is a symptoms of any inflammation, suppose the patient gives a history of fever, night sweat, or sometimes even a Q1 can give rise to a symptom which is concordant with the nocturnal symptom. So these are the times. But overall, cervical pain, my strategy of the management would be first to be the conservative. Tractions, I am not too proponent because the disc is very soft. A traction can pull that soft part of the disc into the canal and can cause aggravation of the radiculopathy to the myelopathy. And subsequently,
if I have to choose the operative management of the disc, depends on whether it's a single level or multiple level, whether the compression is from the anterior or from the posterior. And if it's a young patient, I would usually prefer to replace the disc because then the adjacent segment degenerations can be prevented and the patient remains symptom free for the long term.
So basically,
If you have those couple of cases of cervical disc replacement, if you have that video, you can show us. So you can set up your laptop and you can show us if you. And meanwhile, I'll ask you, Dr. Surana, when would you refer your patient to surgeon?
Most of the patients which I see can be managed conservatively. There are many myths regarding the management of back and cervical pain. First of all, one should differentiate acute from chronic. Exercise has got no role in management of acute pain.
How long you would recommend them rest? Rest, you mean rest, no exercise, rest.
No more than 2 days of rest. So it means you're talking to many patients.
So there-
6 weeks of rest. No rest. Because rest means you are preparing the cardiac and bone which the access provides. So early ambulation, as in the all other orthopedic problems, early ambulation. Second thing is there is a landmark paper, you 25 years back, by A. Radhakrishnan. He was at some time head of environmental neurology and renowned epidemiologist neurologist. Now, his landmark paper was published in this journal, which is very unusual for an epidemiological study. He's basically epidemiologist. He did epidemiological study in Rochester regarding back pain, back and cervical pain management. That what was the result of the surgery? Those who did not opt for the surgery. So, what is expected of this study? You know about this study. This was published in Brain. Brain is basically journal for the basic research. And this study was published in Brain. This is a big achievement, number one. It should be a very good paper. Published in Brain, epidemiological study. So what are the results of that study? Result of the study are that after 5 years, result of surgery or no surgery are functional as well as otherwise. Now, another point is physiotherapy has almost no role, only point, almost no role. This is starting with.
This is a very strong statement. I mean, I don't think
I am
any
quoting
physiotherapist
Harrison.
will agree to you.
I am quoting Harrison. Not to say that. It is written by experts, and the experts are under the scanner of the big corporate. Now, it is not written by physicians. Now, the chapter on that will be written by those who are expert in the banking and management of that.
Because
Okay?
so nowadays, sir, so that is actually the, what I'm trying to tell here is physiotherapists now they have better tools and techniques. Even in acute disc, they have methods for pain relief, not for, they will not do physiotherapy. They will have some methods to improve microcirculation there, pain relieving.
You will be able to bear your deficit bad. That is only advantage.
So basically, so they are
No benefit of adaptation. But in recovery, otherwise there is no benefit. No
yeah,
benefit.
but pain relief is very important right here.
If someone is not doing exercise,
So that's
Don't
what,
say it.
as a neurologist, I think we tend to under-refer these patients. Let's agree on that. So, right, sir?
but thing is that what they say is then about the epidural injection. Almost for 20 years, all authors of Harrison, the authors have been changing, have rejected the epidural injection as a mode of therapy for the
anybody who had this pain, ask you, can you explain this?
Just ask the person who had an acute disc, just ask him, Can he stand?
That is different.
Can
Thing
he,
is that I am.
can he sit in the bed?
No, that is
The
different.
kind
That I
of
will give
pain
medication.
you have, acute radicular, is so severe that during the acute pain, you have to make the patient rest and start the therapy so that
That's what
he
you do.
become painless, then you start mobilizing. Earlier the thing was 3 weeks, rest, lie down and then we
6
will
weeks.
see
6 weeks.
6 weeks, then 3 weeks, then 2 weeks, like that.
No, 2 days.
Now, thing is, you have to do the rest because patient will not even able to turn in the bed.
Now, Dr. Nirmal, in fact, one of my patients who is very young, she had to be carried from home on a stretcher
Exactly.
straight away into the hospital, into the MRI.
Exactly.
And actually, she has now become the brand ambassador for me to entice people to come for spine surgery.
That does not become excuse for the active surgery.
No, I feel that during the severe acute pain, the patient has to rest with the
Yes.
appropriate treatment, start the
Appropriate
therapy.
analysis.
Now there are good physiotherapists who can mobilize the nerve, can mobilize the disc space. They start working on that so that during the acute this may happen. But if patient has an acute pain and if there is any form of neurological deficiency,
Bladder bowel
toe
dysfunction is the
weakness
most
or
important.
the in the cervical region hand weakness or some weakness, severe reticulating pain and feeling that patient is going to get weakness, they should go for early surgery. There is no point in a patient waiting for the pain for 3 weeks, 6 weeks. If they are developing the neurological weakness, immediately go for surgery. Because now the surgeries are so comfortable that keyhole surgery are done. You go through there, remove the disc. You are not removing you are not cutting the bone. You are not removing the pellicle. So everything is you just go between the two bones, remove the disc, and you come out. Patient. I had patients. I'm not naming the ministers, big ministers. Central level. I got them operated and within 24 hours send them back. 24 hours. So you have to choose your patient, what sort of patient you are getting. There is no this thing that Harrison said, no role of physiotherapy. No. There are patients with acute disc who refuse to go for surgery. We have treated them with physiotherapy. 12 weeks, they became completely all right.
You treated with the physiotherapy, but the data says that they would have improved otherwise also without physiotherapy.
How would you know?
This is what they say.
Maybe the theory running between the mental dorsal disc nowadays. The dorsal is the oldest system of the pain management. The ventral is the newer one. The dorsal is the 95% is the common disc. The dorsal is the crucial.
See, the life is very simple. Every person get a disease, they will get
I
better.
have got in one of the best.
Get better with how much disability, that depends on how much is the severity. The fundamental principle is stroke patient. You mean to say that before thrombolysis, stroke patients were not getting better? In ancient days, patients were not getting better. The fundamental principle is the healing happens because in the body on its own. The question is disability and suffering along with the healing. What we are doing is we are reducing the suffering, we are reducing the disability. That's all.
Now, then comes another factor.
You make it very interesting and brainstorming session. So you have put a lot of fire into end of discussions.
Still, I have not completed. Another step is there. Lumbar tension has got no role.
Sir,
Very
there are strong people, they can give actions.
Then
Neurosurgeon don't do that.
I go to
No, we are under traction all the time.
I am putting anything. What after another then after it is gone. As good as any other.
I think, sir, we should carry on and on. It's so interesting.
Yeah,
So, I think you can show a couple of cases in 5 minutes. And I
There are
think
many components in back pain. One is reticular. That will be or for ligamental injury and pain and other pain, it will be another. there is specific inflammation and safety prevent. Role of opiates is also discouraged. That this needs to increase fall in the older patient, addiction and obesity. Meaning that you are kept on the management of diabetes, no role for exercise, no role for that.
Thank you very much for your views. Let's try to conclude this by making.
Yeah, I'll just skip through quickly for few of the very interesting cases I have come across recently. So let me start with this case. I will not go and get into any kind of discussions, I'll just run through the videos. So actually we are from pillar to the post. So look at this patient who presented with a neck pain and then MRI was normal. Suddenly she has got a broken neck and it came out to be tuberculosis of the cervical spine. So on the right hand side you see the post-op, middle is the intra-op, before the surgery, and on the left hand side is the post-op MRI. So this is the patient who still have, you can see there is a deficit on the right hand. She is still not able to move the right hand, though recovered. This is the patient with a neck pain, nocturnal. Now you can see there is a tumor mass sitting there. This has undergone a contrast MR and then subsequently we do the CT scan. So CT scan is must if we are in doubt, and CT scan is must before the operating planning. What we are going to do, how to approach these patients with the cervical cord tumor. So this is the intraoperative before surgery. As you can see in the operating room, how she is moving. You can appreciate that there is a definitive weakness of all four limbs with a myopathic hand. And then this is the post-op, the same patient who is able to walk. This is immediate post-op, the next day. Now, either we have an all or none phenomenon, as shared by some of the colleagues that physiotherapy should not be used. I myself have a personal opinion that every treatment has its own role, and like the whole group, as you are seeing, and the center level, there are a lot of opinions. The opinions are always should be respected. Individuals' opinions does matter, but grossly we should not be deviate from a gross treatment protocol which has been used for a long time. So in my opinion, the physiotherapy should be given a trial and in limited circumstances. Now also there are situations where we don't send the patient for surgery until the patient is getting bedridden. So once the patient is getting bedridden, the recovery road is far difficult. So now this is a cervical disc, you can see. This is the cervical cage replacement. It's a peak cage which has been replaced according to the pointer. Now, how it has been presented? Some patient present with a Brown sequoia, some patient present with a radiculopathy, some patient present with a myelopathy. So, pillar to post means omnial signs of myelomalacia should be respected on the MRI. Patient should be given an option of surgery immediately. Recovery or stabilizations of the neurology should be discussed in detail. Reductions of the symptoms, durations by which it will be reduced after a particular procedures, either physiotherapy or anything, should be discussed, and the treatment options should be given to the patients, including the cervical disc replacement. So in this patient, you have seen there are too many options, either cervical laminectomy and the patient is on the prone position. These are the neuro monitoring has been put on. And on the middle picture, you can see the hand of this is a myelopathic hand. And in this patient, you can see there are, cage replacement. This is not an artificial disc. But the problem is this, that there are screws, you can see. And these screws actually get resolved over a period of time, and sometimes patient can develop kyphosis subsequently. And the adjacent level degenerations are further higher, even with the multiple level stabilization. So you move to something called, just look at this scan. You can see the myelomalacia in the middle. So these are the red flags. Patient should be sent for surgery. And after even doing the surgery, the myelomalacia takes longer time to heal. You can see, now I'm talking about the cervical disc. So far in my personal capacity in Udaipur, we have done about 50 cervical disc replacement. Out of that, we have 3 patients who has gone into complications. One patient has Horner syndrome, post-op. which he recovered. One patient had to undergo a replacement of the disc because of not conforming to the strict post-operative guidelines. And one patient had a early fusion of the cervical disc. So what are the indications when we can do? The patient has to be young, it has to be single or maybe multiple level, can be symptoms of radical or myelopathy, no trauma. No trauma, cervical spine trauma should undergo cervical disc replacement because this is a mobile segment. As you can see, it is made of ceramic ball and cup. So the ball moves and the cup moves once you put the disc. So as you can see, this is the discectomy been going on, and on the right hand side, this is the disc replacement been done. You can see the size of the incision. I will show you the X-ray. Now on the right hand side, intra views, you can see we have opened the PLS, the hook has gone into the canal, so this much of decompression is must before putting the cervical disc, because otherwise these discs are going to remain there and it will cause further compression. So now this is the disc which you can see, it is the disc which has been replaced. You can see the cup portions is on the bottom and the ball portions is on the top. So it gives the neck mobility. Neck, you can see the spinal curvature being maintained, no neck stiffness, and can be done in selective cases, long-term reliefs. This is the metamorphosis when I started my practice many years before, and then now how I have moved into in case of cervical spine. So in a single level, I will do cervical disc replacement. In a trauma, I will do cervical plating with an interbody cage. In a degenerative myelopathy, old patient, osteoporotic, I will do this middle part I will choose. So I will share, if you have time, one spine surgery in the cath lab. So osteoporotic spine fracture, you can see, osteoporotic spine fracture. Now, how do you manage it? We give balloons into the spine. This is the balloons being given. This is called kyphoplasty. The balloon is gradually getting expanded. So the kyphotic deformity is getting prohibited. And then we are putting the artificial bone, liquid bone, into that place. So the bone, that artificial bone, causes a little bit of heat reactions over the annulus, and it gives the relief of the pain. So the patient will discharge the same day. This is the patient who is sitting comfortably. Patient was diabetic, hypertensive, chronic renal disease, so could not be given any general anesthesia. So it has to be done under the local anesthesia. We have chosen cath lab not because it is easy, it gives us a four-dimensional view of the spine in the single setting. We need not be waiting for CM to be brought in, so the whole thing moves and we can easily get it done. Now, discectomy and stabilizations, we do it with a minimally invasive approach. So this is a case where the patient has a recurrent back pain. And as you can see, as we have put the dilator, and this is the post discectomy. As we are moving the disc, what we have found, I'll tell you. It's a very interesting case. Now look at this picture. You could see some whitish structure being pulled out. It is not a disc. This particular lady had a severe mid back pain, and then the X-ray shows that there is one part of the bone has got resolved completely. I will show the CT scan later on. Now, this is basically neurocysticercosis of the spine. So she underwent a biopsy first, which came out to be negative, CT-guided biopsy. Relentless pain, not able to sit, stand, post-COVID situation. And then what we did, I will show you. This is the scan. So you can see the whole part of the bone has been like a moth eaten. as if something eaten it. So initial diagnosis was a metastasis. So in view of the metastasis, a CT guided biopsy has been attempted. CT guided biopsy didn't show anything, and MRI shows this. So initial thought could be a tuberculosis, but came out to be neurocystic sarcosis. So we did a minimally invasive approach of stabilization of the spine. So these are the two paradigms. On the right hand side of the screen is how conventionally we can do the laminectomy and the spine stabilizations. On the left hand side of the screen is basically minimally invasive. So minimally invasive is the answer because you can make the patient stay hardly for 24 hours in the hospital. You can discharge the patient the next day. No blood loss, no muscle damage, no back pain after surgery, and patient's recovery rate is very high. So we are talking about the nanolob. It is basically India's first nanolob being done by us here in Udaipur. So this is the intravenous cage which goes through this, percutaneous approach. We decompress and we put the intravenous cage. It has a nanoparticle coating. So it allows the fusion to happen immediately and quickly. So this is how the nanolob being done. Then we put a kind of osteobiology component inside the cage so that it enhances the fusion. And this is how the operation being done. Now this is how the decompression happens. And on the bottom screen, at the end of decompression, you can see this is the nerve and this is the nanolob which you can see. So actually we did not open the midline at all. It's a paramedian transverse approach for stabilizations of the spine. We call it the nanolob T-leaf, minimally invasive T-leaf. Using this same approach, we are going to show the next case where we have taken out an intradural extramedullary spinal cord tumor. So this patient has a back pain, and you can see there is an intramedullary mass lesions which is double shaped, which has been taken out on this. Now you can see how the tumor been hooked out through the same approach. What we have gained in this patient, we avoid laminectomy, we avoid stabilizations, we avoid CSF leak, we avoid dural tear, and also we avoid migrating to another level. So this, you can see the whole tumor being taken out through a small hole, and this is only 14 millimeter hole. So this is the tumor which came out to be neurofibroma. So from bedside to bedside, this is the philosophy which I personally follow, and the paradigm shift has happened. Breaking the new technology, we have to move forward, and every nail is not to be hit with the hammer, so every case is not for surgery. First trial of conservative management, physiotherapy should be given. We have to be teamed up with the neurologist, because I feel as a neurosurgeon, we are not spending much time with the patients for the clinic, because we don't have time, we are in the theatre. So if a neurology colleague is examining the patient and giving you the detail, we have to rely on him, because he is spending more time with the patients and his decision making has to be respected to some point of time. So this is the last follow-up for one of the patient. I will just, if with your permission, just run the video. This is what he is saying. I don't know whether he is, I don't know, I think video is not going to run. No, it's not coming.
It's a distinct knee surgery. It's a MIS. Anish Sohani, resident of Jaipur, based in Jaipur for 2.5 years now. I encountered a problem with the lower back pain, which was radiating into my exact leg, so making it difficult for me to walk and carry out day-to-day activities. So fine, it's fine. Then I was referred to Dr. Miten, who said basically surgery, it's a MIS basically, nano level.
So this patient was shooted the next day after the surgery. So you can see how comfortably he is sitting up. Now what is the future directions? I think we have to talk about spinal cord stimulations. There are many failed back surgeries, there are many failed spine surgeries, there are many failed cervical spine surgery where patients are remaining paralyzed or with an excruciating pain. I think this is the thing which we need to know now. This is a spinal cord stimulator being placed on the cervical spine of a patient. Now this patient had a cervical discectomy done elsewhere. Then he remained paralyzed after the discectomy. And with no hope, he has been put on a ventilator on a tracheostomy. So it was very difficult to wean him out, and he was getting excruciating pain on the both hand and the leg because of the root damage. So we put the spinal cord stimulator and made the patient come out of the ventilator, tracheostomy being closed, and subsequently patient being sent to physiotherapy for partial recovery of the limb powers. So this is how the spinal cord stimulator used to look. You can see the same patients on the right hand side of the X-ray. That's the cervical spine surgery which has been done. So we have gone through the posterior from behind, and we put this spinal cord stimulator. These are all the channels you can see, and this is the spinal cord stimulator's pulse generator. So with that, it was a weird situation, and recently we have done one case only a month back where the spinal cord stimulator has become now wireless. So it's the shift change in the spinal cord stimulations. It is also again a failed spine surgery. This is the stimulator which is connecting with the patient like a cell phone. And on the right hand side is the paddle. These are the paddles which you are going to use in the spinal cord for the stimulator. And I will show you the horrible spine situations of this patient. Now this is the electrodes which you are going to put in. Look at the situations of the spine. We cannot do anything from the front. Patient is having excruciating pain, not able to even sit. So what we did, we put the spinal cord stimulator, and you can see on the right hand side the patient is able to sit by himself with his hand. So some recovery of the hand power has come. And this is the new technology through which we can control the whole program, and we can do as many programming we can do for the patients during the trial period. So that's it. Thank you so much for your kind attention.
So thank you very much. It was very nice presentation. I think we can conclude it here. Probably if you put it in brief. So this is if you are not tired, anybody wants to ask anything? If not, then we go to the last presentation, small presentation of the day. So I think most of them are. So let's make it. So I am not presenting. So be assured. I think this speech therapy is a 10-minute presentation. So that we'll just conclude the session, and then from here we'll just break up after this, right? If we're lucky enough to connect it again. So let's see whether we can make new synapses or not. The whole day we have been learning about, making new synapses, making, what happened? Over to you, Suraj.
Good evening to all. Today I will speak about role of ASLB in post-stroke aphasia assessment and management. When it's come to what is aphasia, then aphasia is acquired impairment of language process underlying receptive and expressive modalities and caused by damage to area of the brain which are primarily responsible for the language function. Aphasia is also
defined as loss of verbal communication due to an acquired lesion of nervous system involving one or more aspect of the process of comprehending and producing verbal messages. When it's come to sign and symptom, then sign and symptom vary from patient to patient, and it also depends on extent of the lesion, location of the lesion, and the duration after occurrence of a stroke. And the main sign and symptoms are that patient with aphasia troubles with speaking, and they have impairment in auditory comprehension, they have impairment in reading comprehension, they have impairment of written language, they have difficulty in naming object, they struggle with finding the right terms or words, they uses strange or wrong words in conversation, they speak in short sentences or phrases, they uses unrecognizable words. When it comes to etiology, then aphasia is caused by damage to the language center of the brain, and the most common causes of aphasia is traumatic brain injury. In traumatic brain injury, closed head injury is most common cause of aphasia, and a stroke. Progressive aphasia is caused by brain tumors, infection, dementia, and the transient aphasia is caused by epilepsy and the migraine. Good Glass classified aphasia in 1974 in two terms, fluent aphasia and non-fluent aphasia. Fluent aphasia is again classified in four categories, which is Wernicke's aphasia, conduction aphasia, transcortical sensory aphasia, and anomic aphasia. And non-fluent aphasia is again classified in Broca's aphasia, transcortical motor aphasia, isolation aphasia, and global aphasia. According to Good Glass and classification 1974, there are 8 types of aphasia, which in first Wernicke's aphasia. Wernicke's aphasia is characterized by they have difficulty to understand others' speech and produce meaningless speech. They have impaired reading and writing. Their inability to produce sentences that have hangs together. Conduction aphasia is characterized by difficulty in repeating something someone have just said, and they have good language comprehension and mild impairment in conversational speech. Anomic aphasia. Anomic aphasia is characterized by inability to supply the words for the very things the person wants to talk about, particularly the significant nouns and verbs. They find difficulty in finding words in writing as well as in speech. Transcortical sensory aphasia, characterized by fluent speech with some anomia, poor language comprehension, and echolalia. When it's come to Broca's aphasia, then the speech is severely affected. They are often limited to short utterances of less than 4 words, and they have limited vocabulary, clumsy formation of sound, difficulty in writing, but good thing is the ability to read and understand speech is intact. Transcortical motor aphasia. People with transcortical motor aphasia is characterized with they do not speak unless they are strongly encouraged to do so. They have labored and non-fluent speech. Global aphasia. Global aphasia, patient with global aphasia struggle with speaking. They have severe impairment in forming and understanding words and sentences. They have difficulty in repeating backwards or phrases. They have inability to read or write. Isolation aphasia is almost similar to global aphasia, but they have preserved repetition. When it comes to assessment or management of aphasia, it is very much important to understand aphasia types and its localization. Broca's aphasia is localized at posterior inferior region of the frontal lobe, which is denoted by area number 44, 45, and often sometimes 46. Wernicke's aphasia is located in posterior superior region of temporal lobe, which is denoted by area number 22. Conduction aphasia is located at arcuate fasciculus or supramarginal gyrus. Anomic aphasia is located at in